And then we're going to shift gears a little bit, and we'd like to take a few minutes to honor and remember our first AAHS president, Dr. Joseph Danyo. So as many of you may know, we lost a colleague and a friend and a big supporter of our association. Dr. Danyo passed away last year. He had attended the University of Scranton for his undergraduate degree, and then Jefferson, my alma mater, before going into the Navy, and then ultimately doing his training at the State Hospital for Crippled Children and his fellowship at Grace Hospital. He ultimately founded an orthopedic group and was there until he retired in 2019. He was our first AAHS president from 1970 to 1972 and was very active within the association. He was on the program committee, he helped develop the bylaws, he was part of the newsletter, and he chaired our first meeting in Montreal on October 7th in 1971.
In the first newsletter of the American Association for Hand Surgery, Dr. Danyo stressed the importance of modern progressive care of the hand and stressed the need to disseminate new knowledge and set the tone for policies regarding membership in this new organization. In thinking about membership to the Hand Association, he stated, "The Constitution bars any restrictive covenants such as lineage, geographic location, professional stature, or any other form of country club barrier. In this manner, we desire to attract all those interested in actively participating in surgery of the hand." And as our presidential address articulated, our society is founded on inclusion. He also voiced the guiding principle of the American Association for Hand Surgery as an inclusive organization for all surgeons and therapists with background and training in hand surgery. Dr. Danyo is a man of many talents. He was also very involved in the Pennsylvania Medical Society and served as their 140th president. In addition to his work in medicine, he also had some outside passions. This is an article written about Dr. Danyo, which is entitled "From Caring to Patients to Caring for Startup Businesses." Dr. Danyo actually had 4 retirements. The first one was retiring from his leadership position at the Hand Association. The second was when he stepped down from the Pennsylvania Medical Society. The third is when he wrapped up his orthopedic practice in York. And the fourth is when he stepped down from SCORE, which he founded as a business mentorship organization. From setting broken bones to setting businesses on the right course, Dr. Joe has made a difference in York. That is also true of our organization. As everyone knows, the Danyo Lecture, which is a foundational aspect of the Hand Association, was begun in 2007 to honor his legacy. You can see the outstanding luminary hand surgeons who were chosen as the Danyo Lectures initially, and this tradition has continued over the past decade.
Dr. Danyo is survived by his 5 children and 17 grandchildren. And these are some family pictures of him and his wife, and probably one of his greatest accomplishments. This is all of his children and grandchildren all together on a family vacation. Some words I wanted to share that was read at his memorial and also part of his obituary. He was a man who went above and beyond to show his abounding love, generosity, and genuine interest in his rich group of family, friends, and the many patients he took care of, and really all people who came into his path. His vibrancy and humor brightened so many lives, and the lessons he taught us about life will never be forgotten. Joe had such a brilliant, sharp mind with an ingenious memory, and all were amazed by his expansive storytelling, joke-telling, and deep conversations, even about things in the distant past. There was a spark of mindful, charismatic energy about Joe that lit up everyone in his path. He not only changed lives as he applied his brilliant medical knowledge, operating skill, and acumen to every one of his patients, but he focused on connecting with his patients to make them feel heard and uplifted in the midst of their illness. When people think of Joe, they remember a great, influential, passionate person who made them smile and who brought a high point to their day. He changed lives and taught us so much about how to truly live life to the fullest. Joe is someone to strive to emulate and his powerful legacy will continue to shine brightly for eternity. Joe Danyo was a quiet, humble, great man. He never sought the limelight, even though he deserved it. And I just wanted to read, Kyle and I had the privilege of talking to Dr. Danyo's family. He had 5 children, 2 of them went into medicine. And this was a story that his daughter Cindy told me. As a kid growing up in York, I felt very proud of my father because his popularity was especially palpable. Our family would go out to any restaurant, and there was almost always someone in the place who was all thrilled to see Dad and saying how thankful they are for what he did. I even got out of a traffic ticket one time when the officer who pulled me over saw my license had the last name Danyo. This level of popularity is a testament to his special level of care that he gave. Dad's love for people showed in how intentional he was with connecting with all people in his path. And I think Dad did this with so much intention to make sure he left his indelible mark in the world.
One additional quote that I enjoyed was that the Danyo children, 2 of whom are physicians, as Merritt just mentioned, have talked of how they've admired their dad's very hands-on, exceptional physical exam skills, which he applied to a degree that is not as commonly seen these days. He touched and examined the patient in the areas of concern, palpated, tapped, pressed, moved the limb, and listened to the patient and their story. And these skills yielded accurate diagnosis and patient confidence and satisfaction in his abilities as their doctor, a doctor who truly cared for them. Dr. Danyo retired from his orthopedic practice at 65, but never stopped serving people as a doctor. We would like to call up our president, Dr. Dzweirzynski, to introduce the Danyo Lecture for 2024.
Well, the Danyo Lectureship is the highest honor that we give anybody that's a member of the American Association of Hand Surgery. And I truly today have the honor of introducing somebody that needs no introduction, Dr. Wendell Merritt. Dr. Merritt graduated from Davidson College, did his MD degree at University of North Carolina, and then general surgery, University of Florida. His training was interrupted when he served his country at Vietnam, earning the Bronze Star for his reconstructive surgery work at the Hugh Leprosarium. He then entered a plastic surgery program at the University of Arizona, going into faculty at the Medical College of Virginia, and is now clinical professor of surgery in the Division of Plastic Surgery at VCU. He, of course, has been a past president of the American Association for Hand Surgery and the American Society of Peripheral Nerve Surgery. He's been, of course, people know in plastic surgery, winner of the Iron Chef Award every year. It doesn't give anybody a chance. And I think the greatest honor is if you're giving an instructional course and there's 2 concurrent sessions and you see Dr. Merritt, you know this is the session to go to. For every time you learn something new, and it's truly an honor to honor Dr. Danyo's legacy with Dr. Merritt. Thank you, Wendell.
Thank you very much. I'm humbled by this opportunity to speak to you. Joe Danyo was a friend to me. He was always upbeat, and he always had a joke to tell. And I'm disappointed that he's not on the front row as I had hoped. This is a very difficult topic, but I'm going to try. I have no disclosures other than the fact that I've been a student of this topic all my career, and unfortunately, I've been a miserable failure insofar as giving you any universally successful treatment regimen or even explaining why some people develop this. So why am I subjecting you to a discussion of my failure? Well, I aim to try to talk to you about what I think I may have learned in this failure. For one thing, why this is such a difficult topic to study and why it's so incredibly controversial, some plausible ideological mechanisms, and some common sense principles that may help manage these patients and may even be able to avoid development, although I can't prove that. And apart from that, I'm sort of beyond my warranty now in my extra innings, and my hope is to stimulate interest in this topic among those of you who are younger than I to solve this conundrum. And as I look, I don't see anybody out there that's older than I am. There are some controversial generalizations that I want to make. First, I believe this is predominantly a central nervous system dysfunction, that it may start from a peripheral nociceptive or other feature and centralized to other loci in the brain. I think there are recognizable patients who are at risk for developing this, and you need to treat them expectantly. And I believe that early recognition of some of the symptoms is an opportunity to prevent the disorder, although I cannot obviously prove that. The earlier the diagnosis and treatment, the better the prognosis. That's true in multiple, but not all, of the treatment reports. So why is this so hard to study? It's because we don't have objective diagnostic criteria or really validated methods of studying the outcomes. And this is because we're dealing with a clinical syndrome. Clinical in that there's no specific test that is absolutely verifiable for this disorder, and syndrome because it's a set of symptoms that seem quite varied and findings from a lot of different inciting factors. I hesitate to say the term cause because I've been an expert witness too many times. Most of the patients have extremity injury, either injury or have had elective surgery that have this disorder. But if you look in the literature, you find a potpourri of different conditions that have been reported causing this. The ones I underlined when read are ones that I have seen and treated: cancer, stroke, meningitis, venipuncture. And the criteria doesn't include it, but the neurology literature certainly identifies about 10 to 30% that occur spontaneously. I've seen people that have had facelifts, hidradenitis, finger paper cut with devastating result, and recently heard about a flu shot that caused loss of function and did not respond to multiple nerve releases. This is a patient of mine with meningitis, and gradually he really began to use his hand again after about a year. The confusion is further because of the fact there are two different types of complex regional pain syndrome. Silas Weir Mitchell, the man in charge of nerve injuries for the Union Army, had a brilliant description of this as the first description in soldiers who would fill their boots with cold water and stick their feet in them after a, usually I imagine, femoral nerve partial injury in order to get rid of the pain. So he named it causalgia from the Greek. He noted that if there was a warning that there might be an attack from the rebels, the symptoms would worsen in these folks. So it's specific to nerve injury. The onset's usually immediate. The course often has some degree of improvement, but it's a disorder that would respond to sympathectomy in many cases, although his son, 25 years after the Civil War, still noticed some of those patients that had continued to be symptomatic. So if we think in terms of the nerve in the periphery, and if you injure a nerve, as this research project did with severe stretch injury, the inflammation that's present is not confined to the nerve. The dorsal root ganglion has tremendous inflammation, as does the dorsal horn in the spinal cord. And even on the normal side, there can be some, and the spinal cord shrink and white matter disappear and so forth, so that there is a central nervous system change with even a nerve injury. And you think, what kind of garbled information is the brain going to get from a nerve that has that much destruction along its path? And at the supraspinal level, Sunderland and Seddon both acknowledged that at wartime there was a much higher incidence of causalgia. That, in fact, Sunderland had the impression that most likely it was the increased activity of the central nervous system that led to the problem, like your automobile engine running really fast and you suddenly put it in gear, so that the brain responds in an abnormal or incorrect fashion because of this degree of activity. I'm going to show you this case just to kind of point out the confusion. This young woman was sent to me by her parents because she had cut her hand washing dishes and had a lot of complaints of discomfort and dysesthesia, and had a nerve conduction study that said her nerve conduction was normal, and was referred to a pain clinic, and they had been giving her sympathetic blocks and opiates, and she hadn't gotten better, so they asked me to see her. We did Sims-Weinstein monofilament measurements, and you see a pattern of decreased sensation in the median nerve. She has some decreased function in her abductor, and her Tinel sign is over the scar, and she obviously has a partially cut median nerve, about half of it, and a neuroma in continuity that responded to surgery. She does have hyperesthesia. She did have some skin changes, color. She certainly had decreased motion. So you could say she had complex regional pain syndrome by those criteria, although there's another diagnosis that does it possibly better explain. So there are those of you in the audience that I'm positive would say this was complex regional pain syndrome, and I corrected it with surgery. Or I can say, no, it wasn't. It was a partially cut median nerve, and it wasn't complex regional pain syndrome. It was her partially cut nerve, because I would contend that's a better diagnosis to explain it. So we're stuck with these arbitrary criteria. Is her pain disproportionate? Is her dismay and distrust that she has adequate? Is the suffering she has to an amount that would make it complex regional pain syndrome? Or is it really just what somebody gets when you've got a half a cut median nerve and nobody's diagnosing it correctly and you're going around trying to use your hand? Hyperpathia, allodynia, again, are subjective criteria by the surgeon. So you understand that it makes it very difficult when you're trying to compare one person's study compared to another. Now, Sunderland was very pessimistic about any surgery in these patients. And he basically said you have to follow them long enough, and most of them after surgery get recurrence. And I'm sure in his experience that was so. But we do have successes, and I suspect that most of the successes that we see, and we're seeing more now, are probably patients who do have causalgia features more than what we call reflex sympathetic dystrophy. That's type 1. Type 1 CRPS was identified about 83 years after Silas Weir Mitchell's description, in particular to distinguish them from the patients that are said to have causalgia. Evans pointed out that these are patients that might have just sprains or fractures or fairly not very severe injuries, but they had the same manifestations with dystrophy and all the degree of pain that you see with causalgia. And I think this is the treacherous group of patients that you've got to watch out for, particularly considering surgery. Their pain is not so nerve-oriented. It's often glove-like or stocking-like. And interestingly, trigger points, he reported, were present in 63% of the patients he had. And I'll digress a little and talk about the lawsuits in which I've been an expert for the defense. Of the 29 cases, 23 had more than one operation and all got worse. Otherwise, we wouldn't be in the courtroom. And they varied from a paper cut, hidradenitis suppurativa, CMC joint, you name it. And there's a pattern that I want to emphasize. Usually the second or third surgeon suggested that the first surgeon screwed up. He didn't diagnose the problem early enough to be cured, and that's a position of the lawyers. If you go on Google and try this topic, you're going to find about 10 times more advertisements from attorneys for complex regional pain syndrome than you are from physicians. So it's a treacherous area, and you have to be thoughtful about it. And for God's sake, don't try to blame somebody else unless you like being in a courtroom. 3 years before reflex sympathetic dystrophy term was coined, Bunnell wrote his chapter on post-traumatic dystrophy. That's what he called this disorder. And he pointed out that trigger points were one of the first manifestations that you saw. And other people have observed this and reported it, but I find in current literature, people don't believe in trigger points, and a lot of my colleagues say it's my imagination. I think it's an important early manifestation that people need to know about. It's a nodule in the muscle. It's not clear as to why it's there or how it gets there. It's controversial, but almost all the hand therapists certainly know about it. EMG nerve conduction study is essentially normal. This lady was sent to me with a failed carpal tunnel operation, and I'd like to have her audio if anybody can do it. There we go.
Numb and hurting?
Yes, sir.
It's, what kind of a pain is it?
It's the numbness and it burns. All this is burning.
Okay.
And the fingertips are numb. Ugh.
And I've got negative provocative tests.
Yeah, that. I don't know why they're hurting.
You've never noticed that before, huh?
No, sir.
You feel it in your hand or just where I'm pushing?
Right when you're pushing it.
Does it go down to your hand?
Mm-hmm. Yes, it does.
How's it making your hand feel?
No.
Making the numbness worse? Boy, I can feel a real nodule. Is that really hurting you?
Yes, sir.
Stop doing it, huh? Okay, I will. She's got a big nodule in her muscle. Where are you feeling that in your hand when I do it? Which part of your hand?
Right.
Right there. Is that the burning kind of cold pain you've been getting?
Yes, sir.
It is, huh?
Yes, sir.
How about back here? Does this hurt you at all?
Yes, sir.
You feeling that in your hand?
Yes, sir.
Where are you feeling it in your hand?
Right here.
At the very top where you were telling me it was bothering you.
Yes, sir.
Because I can feel a nodule there as well.
Yes, sir.
You didn't know you had problems up there in your forearm, did you?
No, sir.
She was just treated for the therapist treated her for her trigger points, and she never had any progression, had a recovery of normal sensation. When you look at treatment history in this disorder, it's sobering how controversial it is. There are over 50 different techniques that I've looked at, and most of them are published as successful treatments with about an average of 80% patients that were thought to be successful. And there's a variability from vitamin C, TENS, psychotherapy, graded mirror imagery to cordotomy, repetitive transcranial magnetic stimulation, subclavian vein decompression, amputation, a whole spectrum, if you will. And the number of quality evidence-based studies are 0. This was an effort to do so using some Cochrane technique, and again, everything was low quality except for one paper, which was guanethidine not being effective. I think one of the most fascinating papers that was done a long time ago was Susan McKinnon and her group picked the 3 very popular techniques years ago for what at that time we called sympathetic maintained pain, and they studied 59 reports. And in the stellate ganglion block courses, they had about 25 cases. 30 patients in one study had 100% success, and 75 patients in another study had 100% failure. With pharmacologic IV block, I think probably predominantly guanethidine, 100% good in one study with 38 patients, 93% failure in 15 patients. Sympathectomy in their 19 reports, 99% success in a study with 70 patients, 95% failure, 95% failure in another study with 27 patients. How can you possibly explain such results in universities where people are honest? And it has to be because of the lack of objective criteria for our management, and the fact that only 7 of these 59 studies had 1-year follow-up. So let's look at some follow-up. Now, in this study, Sobrero and Stillwell had looked at the charts and found that in their cases that were treated, there was a 77% success rate at 3 months when the patient was discharged, and at their survey, there was an 87% failure rate. Only a fourth of them had returned to work. Wang had a similar result, and they were using only sympathetic block, and the patients at 3 years when they were surveyed had a 78% that were still symptomatic, and 40% of them were worse. But they did something really interesting. They said, let's look at the ones that were treated within 6 months, and the results were reversed. The ones treated within 6 months had a 70% excellent good rate, a good result. So there's probably a message there. That's true of most of the other treatments, not all, but most of the other treatments that I've reviewed. These are 4 techniques that did have a double-blind placebo study done. Phentolamine block was useful for trying to diagnose sympathetic maintained pain. Sympathetic block is still the most used technique in the United States. Guanethidine is not so much used in England, but was, and calcitonin in France. So they studied these cases, and guess what? There was no difference between the placebo and the treatment in these studies. But over one third of the patients did well with either one, the placebo or the treatment. So when the placebo works or when the treatment works, we should enthusiastically embrace it because we're helping the patient. You got a central nervous system problem, placebo effect's going to be enhanced. The best treatment I would suggest is prevention. How do you prevent it? Beware of the patient that has disproportionate pain and anxiety. Give them the attention and acknowledge their pain. Do not tell your physician's assistant to tell them they're going to be okay in 3 months, come back at that time, which is often that happens. You know, there's an aversion for saying you're having too much pain because people say if they look this up, they'll aggravate their pain. I don't believe it. I think if you accept the fact that they're having more pain, get them involved in a therapy program, you can prevent progression. And to do that, you need to know the earliest findings, which, of course, is disproportionate pain. It can be a burning, aching thing, but I think one of the main issues is it's more distressful than you would expect. These people seem to suffer more. Trigger points are going to be present in over half of them, and that's an indication for you. Decreased function, of course. Allodynia, if something like a silk scarf makes them hurt, and hyperpathia, they continue to hurt after you've stopped stimulating them. And they tend to not want you to touch their hand. You know, they withdraw from examination. Now, when the diagnosis becomes easy because of dystrophic changes, the treatment becomes exceedingly hard. So there's an advantage in trying to recognize it early. Another peculiar thing is they disassociate their hands. Their brain is excluding their hand. They carry it around and they talk about it in the third person. They say it instead of my hand. They don't use their hand in conversation the way we typically do. Early on, the graded mirror imagery is one of the most intriguing treatments as far as I'm concerned. It's like you're rebooting the brain by giving it the misinformation that the hand that they think is afflicted is now working really well by using the mirror. McCabe points out, however, that it's successful only within the first couple of months. If you wait 5 months or later, it's usually not successful. When I first got interested in this topic, there was a lot of debate as to whether these people were different psychologically or not, and it was opinion. Maureen Hardy did a study in which she did psychological testing. She used very rigid criteria, temperature change and so forth, for the patients with complex regional pain syndrome, then caused reflex dystrophy. And these patients were different. They were significantly more depressed, anxious, complained of somatic problems, didn't interrelate very well, and they were not to a significant level, but they seemed more dissatisfied with their body. Now, of course, the question is, did the disorder cause this, or was this causing the disorder? It's interesting. Gertzen did her study, repeated it in Europe, and in fact, he got the same results she did, but he did something that was kind of neat. He also discussed with them their status and found that 80% of them had had a recent life event, you know, a death in the family or bankruptcy or stressful things, as compared to the controls that did not have this disorder. I have what I think is insight into the psychological features in these patients because of Jani Theogaraj, who was a psychiatrist trained in pediatric psychiatry, and her husband was my partner, and Jani would come over after her husband had died. She'd come over and we'd have dinner on one day a week. It was my clinic day, and she would see patients for me. These people don't want to see a psychiatrist, and they'll say, "What do you mean psychiatrist? I don't need to see a psychiatrist." But she is so gifted that I'd say, "Well, you might want to talk about your workplace and so forth. We're just going to do this at one time." Anyway, I was quite surprised. She told me these people have alexithymia, and I said, "What the heck is alexithymia?" And she also, because I guess of a pediatric psychiatrist, discussed their childhood. And she found out that the majority of them not only had alexithymia, but had a dysfunctional background. 36 out of 41 of the patients. Now, alexithymia means literally no words for mood. These are people that don't catch on to jokes. They cannot tell you what their feelings are. They don't know. You know, you say, "You seem mad today." "Mad? What do you mean mad? Why are you calling me mad?" And they have what we call concrete thinking. They are emotional illiterates. Jani explained this to me. I wish she could tell you. She explained this to me. If you're a child and let's say both your parents are alcoholic, You may adapt to that in a lot of different ways. You may handle it, but one way is to learn not to feel. Because, one day they may hit you, and the next day they may love you, and so you just simply learn not to feel. And you never do develop an understanding of your emotion, and your brain has difficulty interpreting what is going on, whether this is a medical problem or whether it's an emotional problem. Your brain can't process it. To her credit, when Janie was doing this, it was a clinical diagnosis, and later the Toronto alexithymic scale was invented, and in fact, a very large study in Japan demonstrated that people with chronic pain, more commonly alexithymic people, do have a significant increased incidence of chronic pain. Although the researchers were unsure whether that was, again, a product of the chronic pain or whether they were people who were at risk for chronic pain, and I think the latter in view of Janie's findings. As was mentioned, I inherited a leprosarium in Vietnam and didn't know what to do with it. The German dermatologists had been assassinated, and fortunately Paul Brand's writings led me to be able to handle it, and I revere Paul Brand. We later became personal friends. This one man changed everybody's view of leprosy for 2,000 years and said, to accept these people, now they're not isolated and imprisoned the way they were when I was in Vietnam. We became personal friends. When I was president of this organization, he was my guest speaker, and his talk was entitled Pain, God's Gift to Mankind. He later wrote a book that if you haven't read it, you really need to. It's a wonderful book, The Gift of Pain, and I strongly recommend it. But we were talking about the difference in these patients. His patients, he said, are imprisoned by their blindness, so they don't recognize warning signals. And my patients are imprisoned by the blindness to emotion, that is the group with alexithymic. And the useful emotional warnings are distorted and are perceived as somatic pain. 8 months ago, my son was killed in a automobile accident on the way to have coffee with me. When it was obvious that this was a fatal injury, head injury, he was put in a room by himself and I, the two of us. And I have never had such pain in my life. It was the worst pain I've ever had, and I thought to try to describe it. And it's difficult to try to describe it. It was like fear, but it wasn't fear. In the pit of my stomach, it felt really peculiar, maybe a little bit like the way you feel if you're standing on the edge of a high cliff and you're afraid of height and you have no railing and you're looking over, you can get this funny feeling in your lower lip. And there was a kind of a hollow spot, my anterior chest. Breathing was kind of difficult. Deep breaths, a chaotic set of emotions, unreal sense, numbness, and then shooting horrific moments, almost waves of shooting pain. It occurred to me that if I didn't know this was grief, and I went to an emergency room and tried to describe it, the emergency room doctor would be puzzled. I'm sure I would get a X-ray done, and probably lab studies, blood work done. And then when he came back to tell me that you're normal, there's nothing wrong, I'm sure I'd be enormously angry that he was so oblivious to this horrific pain. So I can empathize with how difficult it must be for these patients. While I was there, a chaplain came around midnight, and a young fella and asked me if I wanted him to stay there, and I told him no, that wasn't necessary. It was near midnight, and but he decided to stay anyway, and I was damn glad he did. Having somebody there that cared with me was enormously helpful. So if you agree with me that there might be people that are susceptible to this disorder, there's a little bit of neurology suggestion that there can be some genetic, it occurs in some families more commonly, and maybe there's this predisposition in patients that have alexithymia or impaired childhood, or current life circumstances with a brain jacked up real high, it's like in combat, or if you have something like a stroke or cancer, or meningitis that scrambles your brain a bit, or even neuroma misinformation going through the spinal cord after it's been damaged by the. But you can say to me, okay, Wendell, there may be susceptible people, but how are you going to explain this inflammation and this stiffness and the osteoporosis? And, well, the MRI studies demonstrate that on the side that's normal, you get a typical somatosensory cortex response. On the side that's affected, of course, it's the opposite side of the brain, you have less response in that portion of the brain, and it's a widespread involvement of the blood oxygen and involves even the midbrain and the motor areas, so that it's definitely a difference. This has now been true of a number of different studies that are not all identical, but there's a spread to the thalamus and insula, and they actually are able to demonstrate that there's a proportion that seems to be related to the degree of pain, and if the person gets well, it changes back the way it must in the mirror image patients, I imagine. And emotional pain has a similar pattern that's not specific. So the reduced somatosensory response involved a much wider spread and the one thing about this to me that's exciting is that this could become the parameter we need for objective measurement. Now, about 83 years ago, Lewis believed that we would find substances that are released that are inflammatory mediators by the nociceptive nerves. And of course, now we see substance P, calcitonin gene-related peptide, many neuropeptides and cytokines that seem to be involved. And the areas involved are mainly the hand, leg, and face, where we have so many density of nerve endings. And we know that now that substance P is released and other factors. One of the most interesting things is if in text mining, they find that nuclear factor kappa B is a common feature that matches up with manifestations of complex regional pain syndrome. And it's a transcription factor that enters the nucleus and can enter mitochondria and program genes to cause inflammation. There's a lot of interest in whether it is involved with connective tissue disease, and so as a consequence, inhibitors are being made for it. There's only one that's on the market yet, and that's been confined for multiple myeloma, but that's a kind of exciting prospect and might be a treatment we see in the future. Substance P, of course, is the pain mediator, but it also is released at the nerve endings and causes a potpourri of inflammatory responses. And it's the best studied of the neuropeptides related to this. What a lot of people don't think about, though, is the endorphin, the endogenous morphine. That's how that word was invented. It's a very potent opioid. and it inhibits substance P release as well as substance P synthesis. It's released mainly from the pituitary. It goes to the forebrain and gives you relief of pain and releases some dopamine. But it also is released into the circulatory system and, as I say, inhibits substance P. The placebo effect is related to the endorphins. This study demonstrated it very clearly when they were injecting the placebo in volunteers. It's interesting, if they gave them naloxone goes to those opioid receptors and blocks them, so that they had no placebo effect whatsoever. There's a message there, and that is, as far as I'm concerned, try to avoid giving opioids to these patients, because you're cutting off their own endorphin system. If you give someone opioids, the endorphin system slows down, doesn't work, and not only that, but some of the opioid receptors will disappear in studies that have been shown. This is an interesting study that I like, in which the nurse whispers to the patient, "I see the doctor parking his car. He's going to be up here with your pain shot in a little while." And they demonstrated a tremendous amount of enhancement in the placebo effect by doing that. Now, I would suggest to you that if she had whispered, "They're going to bring that shot up, but it doesn't have anything but salt water in it," that it might not work. As far as I know, nobody's done that study, but I think you and I believe it. But I think they have to have faith, trust, and confidence for this system to work. It's also interesting, and these people studied a lot of patients with complex regional pain syndrome, and the ones that were over 6 months did not have a placebo response. So people who have this disorder over time maybe are less able to have a response. So, is there any hope for this in the future? Yes, I think so. I think that the functional MRI may give us the parameters we've been looking for to have objective criteria. That some inhibitors of some kind that are mediators of the neuroinflammation may be inhibited in the future. And I'm just so excited about the results of targeted muscle reinnervation and regenerative peripheral nerve interfaces. This is going to be a game changer as far as I'm concerned, because it's going to prevent, hopefully, a lot of people from developing CRPS that have amputations. And it may also work for patients who do have established CR. But in any case, it's going to help us a lot to figure out whose neuroma is going to cause this compared to people who have neuromas and don't develop this disorder. It's a very exciting, I think, time to be interested in this topic. Meanwhile, what are we going to do? Well, the best treatment is prevention, even though I can't prove that you can do that. I firmly believe that you can prevent this disorder if you intervene early. Certainly, I think the earlier the treatment, the better the prognosis. The literature I see says if you can do it within 6 months, you got a much better chance. When you're treating these patients, I suggest you individualize. If it's neuroinflammation predominantly, steroids, I use Lyrica or Neurontin on just about all of them. But if it's temperature changes, temperature biofeedback, just whatever that patient's manifestations, but start with the least invasive and morbid treatment. You try to do no harm. Now, of course, if you are blocking their nerves and it's all to one nerve area and it's more of a causalgia situation, then surgery seems warranted. It's interesting that the medications that do the best for this are anti-epileptic medications that involve the central nervous system. Avoid external fixation when you can easily, because We know that the incidence is higher in people who have external fixation. I think this probably supports their unconscious idea that they're a victim when they look at the hardware. Early active motion and use is a real help. When Hirth and Howell did their scoping review on relative motion, they did not, over 300 cases that they studied, they did not find one single case that had developed complex regional pain syndrome, which really surprised me. But I assume that the reason is that the patient didn't have as much of a self-perception as a victim since they were using their hand. For the same token, if you can stabilize a fracture and have them move as soon as possible, do so. If you have to operate on these patients, and we do have to operate on these patients, the incidence of recurrence and migratory complex regional pain syndrome is quite high. In 8 studies I reviewed, it's varied from 15% to 72%. The most common was the contralateral, the mirror image problem, 52%. And that surprised me because you would think that the hand that had first been involved would be the most common. Same things with legs. You can get it's really important to be aware of this. And you can do something about it. The ones with the red checks have been my favorites. Probably the most important is axillary block. Even if you're using a general anesthetic, you want to try to keep that brain blind to the peripheral nociceptive input. Like I say, I like axillary block, ketamine, Neurontin, clonidine, and tramadol without the E, and vitamin C. And you do need to continue treatment with Lyrica or Neurontin or whatever. If they have trouble sleeping, amitriptyline is my choice. But the main thing is to treat these people expectantly, and you can operate on them and not have recurrence. The axillary block is the most significant, I think. A group of anesthesiologists randomized patients and found that a difference between 4% and 72% recurrence rate. So I think that is the one thing I would be absolutely certain to do. And then take your choice of Versed or ketamine. But do something. Don't just operate on them. I've been there, operated on patients and had them have a recurrence. And after using this regimen, as far as I can recall, I haven't had a recurrence. Communication with these patients is important. Miller said that they need support and compassion as you would a patient with connective tissue disorder. They need validation. They shouldn't be dumped on a pain clinic. You don't just try to get rid of them like they have leprosy. If you're going to have the pain clinic see them, tell them to come back and see you in 2 or 3 months and tell us how it's going. Show them that you care, that you're interested in taking care of them, and don't discharge them. I learned that the hard way. You tell them, come back next year. And if they don't, that's fine. But give them some hope that you're not going to lose interest in them. It's been a real privilege to talk to you about this, and I want to leave with my most important message, which is a quote from Paul Brand. It is by caring for your patient, conveyed with your touch, that you're able to restore peace, trust, confidence, and help them to have self-healing, often your greatest contribution. So I would say, with your compassionate heart, perhaps you can give them the faith in their head to activate their endorphin system and get rid of the pain in their hand. Thank you.